Great, thank you, Paula, and good afternoon, everyone. My name is Eric Isselbacher. I'm the director of the Healthcare Transformation Lab. And on behalf of the entire HTL team, I'd like to welcome you to the Novelline Speaker Series. This is a series of quarterly talks in which we invite speakers from a variety of backgrounds, both in academia and industry, to share with members of the MGH community their lessons and insights about the process of healthcare innovation and transformation. We're very pleased to welcome today's speaker, Dr. Kevin Schulman. And to introduce Dr. Schulman, I'd like to turn the screen over to my colleague, Dr. Jared Conley. Jared is both an attending in the MGH Emergency Department and the Associate Director of the Healthcare Transformation Lab. So Jared.
Excellent. It's great to be with you all. I have the privilege today of introducing Kevin Schulman. Kevin is the appointed professor of medicine and associate chair of business development and strategy in the Department of Medicine. He also is the director of industry partnerships and education for the Clinical Excellence Research Center, otherwise known as CERC, at the Stanford University School of Medicine. And by courtesy, a professor of operations, information, and technology at Stanford's Graduate School of Business. In addition, he's the director of Stanford's master degree program, the Master of Science in Clinical Informatics Management, and I'd encourage you to check that out. Kevin's had a storied career of having impact in organizational innovation in healthcare policy, and health economics, with over 300 original articles, and had very broad impact in numerous journals, and is also senior associate editor of the Health Services Research. On a personal note, Kevin and I met several years ago at a White House conference there in Stanford. That very background you see in his lens. I think at the time he was at Duke. But we met there, and I've honestly just been following his work ever since. He's got a very unique lens that I think you'll hear from today of business and medicine, and the important mix that is healthcare. So with that, we'll turn it over to Kevin.
Well, thanks, Jared. Thanks, Eric, and for inviting me, and thanks, Paul, for all your help this morning. Jared really kind of challenged me to talk about digital transformation in healthcare. I'm at, as Jared said, I moved from Duke to Stanford. Actually, I had a little stint at Harvard Business School as well. So there's some Harvard slides in here too. But really challenged me to say, we're all excited about digital. Stanford's all about digital. We're all machine learning all the time, or at least were before COVID. But why is it that we're not getting traction the way we had anticipated from all this technology? So my challenge today is really to try and walk through what are the gaps that are holding us back. So to start, let's go back to think about the vision or potential to use technology to improve quality and reduce costs, which we all think technology should be able to do. And what are the ways in which technology can be applied to do that? Well, we could improve prevention by increasing uptake of guideline-based care. We know about challenges in that direction. We can enable early intervention before complications occur. We've been trying to do that for many years as a theory. We could reduce utilization. Can we keep people out of the emergency room? Can we reduce hospitalizations by intervening early, or maybe by providing different levels of access or digital technology to deliberately reduce resource utilization? And through all of this, improve our quality of life and maintain independence for our seniors. So the vision has been there for a long time. And our application of this generally has been this concept of a learning healthcare system. There are all kinds of different ways in which this has been depicted, but we have our current state that we'd like to improve. We have our goals of what we'd like to achieve. We do some kind of intervention, we measure the outcome, and then we go back to where we're at. We also know this is a plan, do, see, act. So we see these kinds of things all over the place in terms of quality improvement kind of paradigms. and so the guidelines, patient engagement, monitoring, feedback, and analysis all feed into this, all supported by technology. And so the roadmap of where we want to go seemed to be really clear. And then we have the reality of where we're at today. So I round in hospital medicine here at Stanford. All of us who spent the last 2 years know what the pandemic's done. And so here's a really early use case in the pandemic where one of the things we wanted to do was send patients home on oxygen. And so I would send people home, novel agent, novel disease course, send them home with this really wild pulse oximeter to their house, and then they would disappear. I would have no idea unless they showed up back in the emergency room what happened to them. How long did they stay on oxygen? Did they feel comfortable? And so basically the technology failed my ability to get meaningful feedback to improve the quality of care. That whole Plan Do See Act fell apart. There's no more, this is to me kind of paradigmatic of where we are in terms of how we think about healthcare delivery in the 21st century. Every one of us should be ashamed at this intervention right here. The idea that, in the middle of the High-Tech Act, in the middle of disruptive technology all over the place, we recorded everything we know about the pandemic on paper records. So we just had the world's largest natural experiment. 160 million of us got a novel vaccine for a novel disease. We have really basic questions about who benefited, how long do they benefit, and we have no information in which to make those assessments at scale. Well, the other reality is, again, coming back to, here at Stanford, during one of the surges or anticipated surges, we wanted to create a clinical practice guideline for our surge teams to take care of our COVID patients, recruiting people who had never taken care of COVID patients. And so one of the issues that we have, our modeling, suggested one of the ways of maintaining occupancy at our hospital was to really concentrate on two things: length of stay and variation in length of stay. Now, I have been rounding on the hospital service, and getting patients home oxygen became a rate limiting step to discharge. And so we came back, and one of the things we wanted to do really clearly was change the way we were being more aggressive about home oxygen and being more aggressive about ordering home oxygen. And again, the question came back: is this safe? And so working with colleagues, Deb Dash, who's an informatics fellow here, and Nigam Shah, it took us 2 weeks and over 300 hours of effort to answer the question: what do we know from our databases about readmission rates for patients with COVID who were sent home on oxygen? We'd seen over 900 patients with COVID by that point. And then two other questions. We order a whole bunch of lab tests in the emergency room. Are any of them predictive of higher risk groups that we should be careful about early discharge because they might later need ICU care? And we ended up writing up this experience of how we put this together, this set of analytics to ask these very, very basic questions about the pandemic. And the shocking thing was not the paper. The shocking thing was a comment from the associate editor. This work should serve as a model for the country. Congratulations. Well, we just said we're doing a learning healthcare system. You would think we'd be doing this all the time with all the different issues that we're facing. And the idea that this one analysis was so novel shows how far we are from our conceptual framework. We had a chance with the Institute of Medicine to look at, this was the National Academy did a series of papers kind of for the transition team, although it didn't come out till much later, of looking at lessons learned. And one of the things we came back to in the pandemic, we used lots of digital tools all over the place. We had all kinds of people out here, trying to help. But what we ended up with was just a proliferation of data silos that didn't talk to each other. And so our comments, about all this, as we look to the future, we have to embrace the importance of data architecture for coordinated national or international response to health crises, and find an effective way to support such an architecture and create the infrastructure to put it into action. And I would argue that this is for the pandemic, but this is actually an issue more generally. How are we going to make and leverage our technology and bring it to fruition? So Jared asked me to talk about strategy, and here's angels landing out in Zion. So this is not Palo Alto, but Utah. And the question is, how do we get from, strategy is all about where do you want to go and how do you get from here to there? And so I want to talk about a couple of things really briefly in my talk today. One is architectures, we just alluded to that. The second is analog versus digital business processes, the role of patient engagement, disruptive innovation, the relationship between disruptive innovation and organizational innovation, and ask the question, why now? What's different now that we have to really address all of these issues? So all of us are excited about facing technologies in terms of the Internet of Things and Bluetooth enabled, all kinds of things. We're doing a lot of work at the top with computer vision. Can we use cameras to help us identify frailty in seniors, aging in place? It's just the technology, the consumer-facing technology is really proliferating, giving us all kinds of opportunities to think about ways of designing interventions that have never been possible before. We've started to build interfaces. Some of these technologies can access our data. Some of our data, some of our systems can access some of these technologies. Then we have separate laboratories where we're collecting other types of data at scale, like 23andMe. And then we have our provider-facing technology, our electronic health records, our population health consoles. And the question is, like, what's the architecture? How do all these different things relate to each other? And I found this really interesting. Here's Microsoft's vision about maybe how this world comes together, obviously with their proprietary technology. But what's really interesting about this, here's hospital technology and patient-facing technology, the Internet of Things, you can imagine all feeding into this, going up to the cloud, and being available for analytics. But the really cool thing about Microsoft's vision of the world is there's no role for Epic in this architecture diagram. So as we think about the architecture of data, where does the data reside? How do we collect and store data so that we can make meaningful insights? How does that relate to a world where we collect information not around the patient, but around the provider? And I'll talk more about that. So what we've done with high tech, and actually I had conversations with David Blumenthal when he was putting this into place. We built hospital health records, and we all know we've adopted technology. It's really good at doing billing. It's not really good at doing machine learning. But it also is not really good at following our patients over time. So again, go back to that very basic use case. Either the Medicare total joint program, where we have no idea what happened to the patient after they leave the hospital when they go to the nursing home because it's not on the same record, or the MyCovid pulse oximeter use case. There's just huge limitations of organizing healthcare information around the hospital. The alternative architecture, which is now coming into being, is organizing the information around the patient. And, for me, I think we really need to seriously consider 21st Century Cures now prevents hospitals from blocking us from building a new architecture around the patient. Our friends at Apple have provided some frameworks that we could use to do this, but we're doing a case study now on India, where a country of 1.4 billion people is going to try and organize records, not around the hospitals, but around the patients. And as you think about the technology we're trying to develop, the learning healthcare system questions we have, if I do X in a patient, what happens to them over 6 months or 9 months or a year? Which of these architectures is going to be more facile for collecting information and collecting information at scale? So the next kind of interesting concept is disruptive innovation. We've had lots of technology in healthcare, And David Cutler up at Harvard and Rob Huckman have a really interesting paper in HBR that I'll come back to a couple of different times, arguing that we didn't have productivity gains in healthcare despite this massive investment in technology. And so, to go back to Clay Christensen, disruptive innovation is both technology innovation and business model innovation. And so we've seen lots and lots of technology innovation in healthcare. We've seen very few instances of real business model innovation, where we've changed paradigms about how we deliver care, how we provide services, or what those services are. And so, we've been very focused on the technology side. In this talk today, from the strategy perspective, I want us to think a lot more about the business model piece of this. How do we use technology to provide a different value proposition to consumers? And one of the ways I've been looking at this, and I use this in class all the time, is to think about a world of analog and digital. When we had paper records, obviously we had this analog world where when we submitted a bill, we submitted a paper bill, and we built lots of processes. A lot of things we do in healthcare are these analog processes. And in fact, the National Academies looked at the HITECH Act early on about the impact of electronic health records. And the first major thing the committee looked at was what was the impact of electronic health records on the size of files in the file room of the hospital. So how did it impact our ability to collect paper records? That was the vision of electronic health records. It was a digital version of a paper chart. And a lot of things that we do in healthcare really continue to follow from that. There's still digital versions of paper processes. And so I'm going to do some illustrations to think about what might be a true digital process. Like if we had to start from scratch, or if you were one of these Silicon Valley firms, how would you think about designing processes to do specific activities? So I show this in class and just take a minute to look at two different financial transactions. One's our health payments model, and one's our credit card payment model. And just look at these cards and the what they represent, but what they represent as business processes. So you all know that the insurance card is really important, really helpful to us. When you go to the doctor, you actually present this. The doctor might scan it, might take a picture of it, has to type it in, or someone in their office has to type in the numbers from this thing, the illegible numbers, into some machine. It's the beginning of an entire analog process of payment. And obviously the contrast is the MasterCard, which is this digital transaction with a digital chip, with digital privacy and security built into it. What's the result of having this analog versus a digital process? We've been doing a lot of work on this. And the billing costs, I'll show you this, the billing costs of using the analog process that we've talked about, it results in this paper we did with Bob Kaplan from HBS. The cost of submitting a bill for a primary care visit ends up being $20.49. And Jared, for you to submit a bill from the emergency room, it's $61.54, and it goes up from there. If we submit a bill using your digital version of your MasterCard, obviously the transaction costs are about 2%. So we're looking at 20 to 30% transaction costs versus 2%. The difference between the analog process of submitting a bill with your insurance card and the analog and the digital version of transactions using your credit card. One of the questions we have from HITECH, actually, President Obama in his signing statement said we were going to reduce administrative costs as a result of implementing digital electronic health records. This paper actually concluded that these findings suggest investments in certified health information technology have not reduced high billing costs in the United States. And in fact, in the sensitivity analysis, if we amortized the cost of acquisition of electronic health record systems over the billing processes, it actually increased the cost of submitting a bill compared to analyses of transaction costs from a decade prior. Could you move to a more digital framework, and could you save money as a result of that? And here's some work we did with Dave Schenker, Brock Richmond from Duke, and Arnie Milstein, where we took actually that paper from Philip Sang and decomposed what was driving those costs into 3 different dimensions: contractual complexity, contractual architecture, and compliance costs. And then we suggested, well, what would happen if we had a more digital framework to support those models? And the result of this is that we could drive down administrative costs under a whole bunch of different modeling scenarios in a multi-payer system to lower than that in a single payer system. And so the issue is not single payer versus multi-payer. It's much more analog versus digital as a transaction platform. I saw this, you may have seen this article in the New York Times about Tesla, and how is it that Tesla has not had problems delivering automobiles during the pandemic when other car makers do? And the argument in the newspaper article was that Tesla was kind of a digital first company. And so the car was designed basically with digital business processes. And so what was happening with General Motors or Ford is that they would buy subsystems that had their own digital piece of it, the engine subsystem, the braking subsystem, everything else. And so they have chips in every single subsystem of their car because some third-party vendor wrote software for that subsystem. And so they need very specific chips and very specific technologies for each of these subsystems, and they buy lots of chips per car. Well, Tesla was digital from the get-go. And so one of the things they did was not buy lots of chips. They would have basically have centralized all the information processing into an architecture that serves the entire vehicle and not each subsystem. So they need less chips from the beginning because everything's digital. But the second thing was, because they're Tesla, when they ran out of one kind of chip, they just reprogrammed a different kind of chip. And so, they were able to take advantage of both of these things, at least during last year, to deliver cars without a hiccup. But it really brings forward this idea about how digital mindsets and digital business processes might improve productivity. And then finally, we talk a lot about data and data architectures, but most of us actually don't care about data and the quality of data. Well, or not the quality of data. We don't care about data. What we care about is services. And if we had high quality data that was accessible, we could provide high quality digital services. And so people say, well, the patient doesn't want their digital health record. And I was like, absolutely not. I don't want one, but I do want digital services. Help me with my diabetes care with a technology that's actually linked to both my providers and my medical history. So high quality data organized about me can provide a platform to provide high quality digital services. And if we were able to do that, then you actually could see pretty significant productivity gains in healthcare. And the importance of this goes back to an article almost 20 years ago now from Rand. Here's the impact of productivity. Here's the current national health expenditure projections. We're at about $4.5 trillion in 2022. And by the end of the decade, we'll be almost $7 trillion system. If we got if digital technology provided the productivity gains that we've seen in the retail industry, we would have a 1% per annum productivity gain. This is, bar scanning and self-checkout, but also automatic inventory management. And that would save us, almost $1 trillion by the end of the decade. But Hillstead talked about the business model transformation of the telecom industry, which went from analog to digital as an underlying basis. And as they did that, he argued they got 8% annual productivity gains. Well, he said there's no way healthcare would ever get that much productivity gains. So he modeled 4% productivity gains. Again, half of what we've seen in other industries that made this analog to digital transformation. And when we talk about flattening the cost curve, you see that here, where basically healthcare spending is almost flat. And so the power of this business model transformation using digital technology is a huge opportunity for us to really dramatically shift the cost structure in US healthcare. I want to take a second and talk about patient engagement and how might digital help us with, things like compliance. Most patients don't take their medications, and realize that digital really transforms the relationship between providers and patients. With Stacy Wood at NC State, we gave this talk called the Behavioral Home, and thinking about developing a systematic understanding of behavioral phenotypes that help explain and differentiate patient choices. And the whole analysis here is that when we go from analog to digital, we also go from one-to-one interactions with patients to one-to-many. But that gives us a lot more tools to think about how we can be more engaging in shared decision-making, how we can build trust with diverse groups of patients, and how we can build different communication models and different strategies for different patient subgroups. What might that look like? Stranger Things is a hit on Netflix. I get excited about talking about it because the Duffer brothers actually went to my kids. They were from Durham, and they went to my kids' elementary and middle school. If you watch Stranger Things, you see all kinds of references to Durham, North Carolina. All the street names are Durham names. But what's really interesting about Stranger Things is if you get an advertisement on Netflix about Stranger Things, it's obviously their search engine, their optimization thing might say, you might like Stranger Things because you like something else. But what you don't realize is the image that you see that Netflix sends you is different than the image that I see. Netflix actually not only customizes your recommendation, but also customizes how they present that information to make it more powerful to you to act on it. And that's really mass customization scale. The amount of analytics that goes behind the Netflix algorithm has been described before. And it's really amazing. So what that might look like in terms of healthcare delivery, you can imagine mass customization that would have different user experiences, different engagement tools or platform, the use of different provider types, convenience, in-person, synchronous, asynchronous, the use of telemedicine, the use of population health strategies to have high tech and high touch, all coming together to really shape a different care experience for our patients. So in terms of these concepts, with Stacy, we applied these to these kinds of thinking about how do we segment populations and how do we appeal to different populations. And we applied that now, not in a digital world, but to COVID-19 vaccination in the United States. And now have had the series of papers about thinking about really tailored communication messages. Not, in terms of COVID, the issue was never the people that were lining up when the vaccine was available in April of 2021. But the issue was always going to be that half the population before the vaccine was launched said they weren't interested. And we've done nothing to get those people more interested. And then the World Bank actually asked us to take these strategies global, which was really kind of fascinating that the underlying psychology of consumers, seems to be valid around the world. But how we apply these things to different patient populations really needs careful thought and development. So, so digital, when we think about digital, we think about telehealth, and we all got excited and learned how to do telehealth really quickly during the pandemic. And here's a paper we wrote with some of our fellows here about COVID-19 and healthcare's digital revolution. During the early days of the pandemic, when nobody was coming in to see providers, We moved to telehealth really quickly. Some of that was just expediency, like it's hard to pay salaries if we get no revenue. But the question is now on the back end, what do we do with this? This is really exciting. We have this novel care delivery platform. We have basically, rather than standalone telemedicine, now we have the idea of telemedicine as a way of extending our care delivery and in-person model. And what might be the economics of this if I'm Partners or if I'm Stanford, or should I continue to do this? Should I put all my eggs in a digital health basket? And so let me kind of walk through the economics of innovation from a provider organization perspective. And we'll look at, again, this case of telemedicine. And so we have an organization, in this very simple organization. We have 3 different service lines. We have $200 million
Just hold on for a minute, folks. It looks like Kevin had some technical difficulties. Hopefully he's jumping back on just now. Just give us a minute.
Not like giving a digital technology talk where digital technology fails. Sorry about that. We're back at this idea about a three service line clinical environment for primary care, orthopedics, and oncology, where we're losing money in primary care. And digital technology gives us a chance to reimagine primary care. And here's a collaboration that Stanford has with Carbon Health to provide innovative healthcare choices for patients. And Stanford's not doing this, but imagine we said, well, you know what, we're losing money in primary care. Why don't we just move all of primary care to Carbon Health? Let them deal with how to integrate technology and business practices. And we're going to concentrate on our destination service lines of orthopedics and oncology. And, it will get rid of a headache. And what happens as a result of that, so we move primary care, we're not losing money in primary care anymore. But all of a sudden, what happened to orthopedics? Well, our overhead cost structure, our legacy cost structure, is now amortized over 2 clinical services. So what we forgot was that we had amortized a lot of our overhead costs to the primary care service. And so now orthopedics is losing money. And so we're in real trouble. And so obviously we should just get rid of orthopedics as well if we follow the logic. And if we do that, all of a sudden oncology goes under, and then we're in real trouble. So what this illustrates is this challenge of overhead cost structure, and how overhead contributes to lots of our economic challenges. This could be legacy costs, legacy business model, legacy infrastructure. but that really limits the way in which we view technology and view our interest in innovating using digital technology. And this was recognized by Schumpeter a century ago. Schumpeter was a German economist. He actually went on to become chair of the economics department at Harvard. But he said, as the rule does not grow out of the old, but appears alongside of it and eliminates it competitively. And a lot of this is around the overhead cost structure. And so here's a brownfield model. We have a great new technology, digital technology. In this case, again, I pick on Duke. This is Duke Hospital. And we decided to implement our new thing in Duke Hospital. And then we asked the question, does it save money? And what you could see is, well, we have all these legacy cost structures that are amortized to the new thing. And obviously, it's not going to save us any money at all. And contrast that with a greenfield model, where we take our new thing and actually optimize an overhead cost structure for it, and then really can become much more efficient. So critical question that we have is, how do disruptive innovation and organizational innovation relate to each other? So what we have to realize as firms, as existing firms in the marketplace, we have something called a business architecture. And this is a business model that we have that's really optimized to allow us to have predictable performance as an organization. So the CEO of your hospital or the CEO of a public company is basically financially incentivized to provide predictable performance to the market. In fact, performance is so predictable, stock market analysts predict, how a company earnings are going to fall within a penny. And so, this is the epitome of predictable performance here. Every single car that comes off this assembly line, you can imagine is going to be exactly perfect. It's going to be a perfect replicate of everything else. And this idea of business architecture, business culture, predictable performance is really a miracle of human society that we've been able to organize ourselves to do this. As a result of this, what we have in terms of predictable performance is a really, in lots of ways, very static delivery models. And this is this Kerr-White cube that looked at utilization patterns in 1996 compared to utilization patterns in healthcare in 2012. And what you see is basically unbelievable graph, 45-degree line, where the thing that predicts utilization is what the pattern of utilization was 20 years before. At Duke, these are the plaques outside the chancellor's office. Duke was a relatively new medical school, started in 1930. And so we really want to celebrate the people who brought Duke Healthcare to light. But if you look at these plaques really carefully, what you see are things that look really common, like the Department of Medicine, the Department of Surgery, the Department of Pathology and Psychiatry. Well, how innovative is a healthcare organization where our org chart is written in bronze basically a century ago? That really shows you some of the business model challenge of innovation in healthcare. So quick story about this thing called the Bicycle Book. Zoe Radner was doing performance improvement in hospitals in the UK, and was really struck that people were lining up at the hospital every morning if they took their bikes to work to sign in on the Bicycle Book. And no one else had to sign in. If you took the subway, you didn't have to sign in. If you took your car, you didn't have to sign in, just if you took a bicycle. And she was watching this over and over again. And someone actually took her to the storeroom where they had all the old bicycle books and floor to ceiling of bicycle books. And finally she said, why is it that people who ride their bikes to work have to sign in? And no one could answer that question. And it turns out during World War II, if you rode your bike to work, you got extra ration cards. And unfortunately, World War II ended in 1945, and we were still following this bicycle book business process to show how innovative we were into when she saw them over the last couple of years. So we're really struck by this idea of the production engine. Our organizations are built around production engine, but we're not providing the cost and quality that society wants. And so we want to innovate. We want to use digital technology and innovate. That's the talk we've been doing a lot of today. And so here on the right is our innovation agenda. which doesn't look at all like the production engine. And so our challenge is like, would you, as you pursue the innovation agenda, would you let these people tinker with the robots? And the answer is absolutely not. And here's the essential problem and dilemma that we have, because obviously the team on the right is Bill Gates, or not obviously, the team on the right is Bill Gates and Paul Allen in 1975 in Albuquerque, and this is the beginning of Microsoft. And so this became a $1 trillion market cap organization. If the picture on the left, a production engine, was General Motors or Ford, or General Motors or Chrysler, that those companies actually, with the optimized production engine, went bankrupt over that same time period. So innovation agenda is a way of creating huge value in the economy, but we're incentivized as leaders and as organizations to grapple with the production engine. And how do we deal with both of those together? And how is machine learning going to impact that? So, as we use technology, who's going to do which tasks will be performed by technology and which tasks will be performed by people? And so how do we not just use technology to replicate tasks, or how do we not use technology to actually make more work because the technology is going to do it and then we got to check it? We also need to think about using technology to optimize work processes. And here's a heads-up display from a 787. And I always get totally jealous of this. You remember the last time you sorted through Epic to try and find some piece of information on a patient, or you got inundated with tons of information and you had to try and sort through it and integrate it all. Well, airline pilots don't have to integrate data anymore. Airline pilots, the computer integrates, the airline's got sensors all over the place. Each engine actually has their own hard drive to collect data that's never shared with the pilot. They use it for machine learning for maintenance. And the pilot is only given the information that they need to help them make decisions in that point in time. They're not actually the ones who integrate anymore because integrating data became so overwhelming. So a couple quick thoughts on how do we achieve this vision. And one of the issues is governance. And Sam Mulganey was actually one of my students at HBS. We wrote this article in Health Affairs talking about the failure of pilots to scale from a business perspective. And basically we said, we should think about technology more as discovery, development, dissemination. And what we're doing generally is we do a pilot for 6 months, and then we ask, did we save any money? And the answer is no. But to go back to earlier in the talk, the definition of saving money is technology innovation and business model innovation. Well, for a pilot, you'd be fired if you did business model innovation because we don't even know if the technology works. But the only way to save money from a pilot is to do business model innovation. So why do we keep asking questions about did we save money from a pilot when basically we never do the business model innovation that would enable us to save money? Really, a pilot should ask the question, is there promise in this technology? Proof of concept is what we do in oncology. And if so, then we need to do the pivotal clinical trial where we do the business model transformation and move forward. So, I showed this slide for years. What if half of healthcare was delivered by mHealth technology by 2025? And it was always an aspiration of some point in the future. And obviously, we've seen over the last year that we could do that. This is data from Stanford about our televisits during the pandemic. And so we could do it. The majority of our ambulatory visits moved very quickly to virtual. We have the capacity to do it. Now, we haven't moved 50% of dollar value to healthcare to digital yet, but that's a potential for us moving forward. And finally, why now? Why have this talk? Why focus on innovation now? Pandemic's over, we can go back to where we were. Well, what we've shown in the pandemic are things that really are not that attractive. The first is, obviously the healthcare disparities and the fact that we failed large segments of the population over the last year. Life expectancy in the United States for whites declined by a year, but for Blacks and Hispanics declined by almost 3 years. In curve 2 here, I got to redo this calculation, but basically the results can be the same. And this is employer and employee contributions to health insurance as a proportion of median wages in the United States. And what you see over 20 years is healthcare has actually grown from 15% of total comp to 30% of total comp. And we're all talking about cost increases coming this summer. But while we've increased the cost, the quality of health insurance and is declined with the emergence of deductibles and high deductible health plans. And so access actually has really been compromised. It's having a negative impact on job growth more broadly. And here's a really interesting paper looking at hospital cost of healthcare and employment. And you can imagine, as we go into individual practice, well, the doctor had an accountant, the doctor had someone that cleaned their office, that wasn't, maybe went out for lunch. They didn't have Sodexo, they didn't have KPMG. And so all of these, all this consolidation that has been going on in healthcare is having negative effects. You can actually think about it tangibly in terms of those services that are no longer being provided at a local level. But you could also think about it more broadly about job starts. So I apologize for a little internet hiccup, but let me stop sharing and take questions that are out there.
Great. Thank you, Kevin. That was just such a phenomenal journey through our world in healthcare and digital. Just going to go to video here. The opportunities that we have to rethink not only kind of the technology innovation, but business model innovation. It reminded me of the article, The Savings Illusion, by James Weinstein and others in New England Journal of Medicine, where they talk about why clinical quality improvement has never really resulted in much savings. And that's all due to the fixed costs of healthcare. And so I'm curious, as you kind of led us through this journey around linking both technology innovation to business model innovation, and getting maybe away from some of these fixed costs of facility-centric care. Could you speak a little bit about maybe groups that you are seeing internationally that are doing the initial work in this space to make that happen?
Well, we've seen, I think one part of the market that we've been looking at is Medicare Advantage. So Medicare Advantage, the business model is really easy. You get a group of patients and you keep them out of the hospital. And if you do, you make a lot of money. Now, so that's in theory. In practice, maybe you code a little bit more aggressively, you make a lot of money that way too. So it's not a panacea, but at least there you can see very clearly this concept of, we can invest in technology, we can invest in really very dramatically different business processes. A couple of the Oak Street and ChenMed really have this idea about organizing the clinic around acuity of patients, which is really kind of interesting. So we're going to give you really high acuity patients and tell you your job is to keep them out of the emergency room. But we're going to limit you to a panel size of 200 or 300. Not 2,500 as primary care doc. So those are out there as a paradigm. I think we've seen, but we've also seen kind of things that may not stand the test of time, like standalone telemedicine as an independent entity has really been challenged over, after the pandemic. People are asking the question, well, now my doctor does televisits anyway. Do I need another vendor to do that as well? So I think those are all going to be fought out in the marketplace over the next couple of years.
Great, thank you. Eric, did you have a question?
Yeah, Kevin, provocative talk, also maybe a little bit discouraging. You make a good case why the administration of some of these hospitals is really incented not to change the production engine because it's working okay. Especially right now when health systems are stressed because of the last couple of years of COVID. It seems like they're less incented than ever to mess with their production engine, just try to keep in the black for now. It seems like a difficult time to convince leadership that innovation is the right thing to do for the future. So what kind of message do you try to deliver, either to the team at Stanford or to other centers where you visit, to try to help them understand that that sticking with your production engine may work in the short term, but in the long term, it's not going to be the best solution.
Yeah, I mean, I think one of the, I would start with, I don't think this is a depressing talk. I think this is a really optimistic talk. The depressing talk is there's no future other than doing what we've been doing and driving up cost increases and these quality gaps that we've seen. So to me, that's the depressing health policy talk. I think our job is to really help understand why these things are so difficult. At an organizational level, and to think about if we're really going to try and innovate and do something for our patients, can we suggest alternative structural forms? Can we provide feedback on building plans? I think we need to continue to push forward. There's a book, I forget the title of it, a couple of years ago, about people who like drag their feet on business models and disappear. Hospitals aren't going to disappear, partially because they have so much political clout. But we can make, the financial pressures you're talking about are self-made. I won't pick on Stanford, I'll pick on Duke about how many billions of dollars we put in the ground. And then our chancellor came to me one day and say, how do we become a low-cost Medicaid HMO? I was like, well, you can't have $1 billion building and be a low-cost HMO, Medicaid provider. So, so I think that voice, a polite voice at the table suggesting, well, we need to think about other things. But as an organization, I didn't show the slide today, but, it's a huge challenge to run an organization that has a production engine and an innovation agenda concurrently. And how do we help leaders understand ways to manage that and get excited by it? The good news is your entire board most likely are people on the innovation side. There'll be one or two Wall Street people who focus on the pennies per share, but there are a whole bunch of people that are there because they've been innovators in the marketplace. And the question is, how do we leverage them to get to build our own internal strategies? And then finally, we should recognize we're all really incredibly privileged to do this. If you ran 100 million in the red, you would barely touch the income you're going to make from your endowment that year. So one of the questions actually our hospital CEO says, what's the endowment for if we can't do these kinds of things? I think we need to be more aggressive about that.
Great, thanks.
A quick question from the audience. Do you foresee future disparities in healthcare technology between rural and urban practices, or will all boats rise with the tide?
Actually, we've been doing some evaluations, excuse me, on telehealth, and actually telehealth didn't exacerbate disparities. But I gave a talk like this to the University of Mississippi Department of Medicine. They said, you realize a large proportion of the state doesn't have broadband yet. So there are broadband investments going in. And to me, I think we need to continue to support that, whether it's for healthcare or education. The future is going to be, people need digital access. So that's a huge thing that the government can do to help us, because that's the last thing we want to do.
Yeah, I love that. Could you speak a little bit more to what you mentioned about letting the digital record be built around the patient rather than the provider, particularly what you know about maybe that India journey?
Yeah, so this is actually not a new concept. We started looking at this a long time ago. And so if you ask the question about, just from basic health outcomes, like, what happened to your patients? Did they end up at a different hospital? Did they end up at a different emergency room? Well, maybe they're not on Epic. How would you ever track a patient over, say, a 12-month period for all their clinical records? Or are all of us on this thing have moved? I mean, if I asked you to pull up your records, where would they exist? I was meeting with the person who was running a health information exchange in North Carolina, and she started with the story about a redo orthopedics procedure that she needed to have on her ankle. She didn't remember the name of her doctor. She didn't remember what the procedure was. And then she went to describe what they were going to do with the HIE. And it's like, you realize with the HIE, you can't even solve your own use case of helping you figure out what the technology and hardware were, and that needs to be revised. And so how do we make data more portable has been an issue for a long time. Now, on top of that is, as you think about digital services, so I want, frankly, I want to use digital technology to compete against healthcare systems, right? I want to force, to Eric's point, well, if the leadership of the organization was competing against a digital powered Google, Verily, whatever, that was a really high powered digital solution, they might make different decisions about, their response to innovation. So, how do I liberate that data to get these services and make them available to consumers? Well, again, if I architect the data around the page, around the hospital, I have all kinds of barriers. We had to put a law in place, 21st Century Cures, to prevent hospitals from blocking me to have access to my legally, my legal access to my data. So I have laws that provide me access. Now I have laws that prevent the hospitals from blocking me to get access. Do we want to organize around a hospital? The other thing was research. I mean, look at what happened with COVID. All of our treatment guidelines came from the NHS. The recovery trials. While I organized helped organize a convalescent plasma clinical trial together with the University of Michigan in Pittsburgh. And in July in 2020, I started giving talks like, do you realize 500 people have touched a piece of paper related to this clinical trial? And we had 5 patients in the trial at the time. And in the UK, they had no problem like organizing very large scale randomized trials at very low cost. So even if the issue is research, how do I organize the data to make it more accessible? And building these data silos at the organization level makes no sense from that perspective.
Yeah, I love that. I'm curious if you could speak as well. I loved your analogy around the org chart being written in bronze. As we think about how technology certainly how technology has enabled other industries to completely rethink how they're structured. I'm curious if you know of individuals that have been writing in this space that could help inform our own thinking around how do we build the next phase of healthcare that is, again, less facility-centric, more patient-centric, more home-driven, in a way that kind of brings together all of the great things that come from the centralization that facility has allowed us over the last century, but still build off some of the technology gains we've had recently.
Yeah, I mean, I think, so there's one stream of literature about the economic impacts of consolidation, negative economic impacts of consolidation, and the impact on price. There's no evidence that consolidations improve quality. We also have kind of downstream effects on burnout of doctors. But we had a fascinating talk last week with the president of the American Nursing Association, where we talked about the breakdown of culture resulting from consolidation. Like he said, he used to know the president of the hospital. If he had an issue, he'd go sit down and have lunch with them. He doesn't even know who the president of the hospital is anymore. Well, that led to travel nurses. Like, why should I stick around and put through this? Why do I have any loyalty to this large amalgamated institution? I should just be out there for the highest price. And so lots of issues of consolidation on market prices, but also on us as the clinical organizations, and the most extreme was on this nursing piece. So you have that the negative piece of consolidation. So there's a big literature on that consolidation, the impact of consolidation on cost, quality, and access. I think this idea about how to, I think it's this Schumper thing. Are we going to change in the absence of real threat to our core business models? And that's a really tough one. And, his vision is these things would come alongside of it. The buggy whip manufacturers didn't design the car. And, the gas engine cars didn't design the electric car. Are we going to see that? Is that our future? That we're going to need a Tesla so that we have to compete against it to change the way we think about our strategies. So I think we have lots of examples of this out there. There are very few examples of, I get in trouble, but I quip, as the CEO of a hospital where you have this production engine running, you have two choices in the morning when you wake up. You can go into work and do business transformation and the hard work of innovation, or you can go play golf, and you got predictable performance all nailed down. Like, which do you want to do? And so I think that's a real challenge for us. But I think part of this is making sure, as we're talking about innovation, to me, it's these business model challenge. It's not the technology. The technology is out there. It's permeating every other aspect of our life. But you also see that there are different kinds of firms that are thinking about how to use that technology to optimize other services. And what we haven't seen is that digital transformation of healthcare services. And whether that's going to come from within healthcare organizations, or, I'd be perfectly happy to use digital to have, like, MGH and Mayo can compete against every other hospital in the country from digital, right? And now the cool thing about digital and, in digital world, you're no longer a physical bricks and mortar, right? You're in social media, you're in the ethos. We all been, Mayo's done a good job, at least on the social media side, of building market share. But MGH no longer has to have a strategy. It's totally fixed on bricks and mortar, and could think about how do we deploy our intellectual assets in a different way. And so the basis of competition could change in that direction too. That would be really cool.
Yeah, I love that. That's a great way to end. Well, thanks again, Kevin. This has been so wonderful to hear your insights, and we look forward to seeing your further work come out.
Well, thank you all for having me, and really enjoyed it.
Thank you, Kevin.
Thanks. Bye-bye.
Thank you all.